Hello, my name is Kyle Moore. I'm a student physical therapist assistant at Jeff State. And today I'm going to be talking to you about my patient in this case who had a rotator cuff repair. So what is a rotator cuff repair? It is when one, some, or all four of the tendons get torn and they have to go in and surgically reattach them to the humeral head. In one case they can use arthroscopic repair, which is nice and because they don't have to make such a big incision, so the recovery is a lot quicker and you don't have possibly a nasty scar. And here's the four rotator cuff muscles, and here's an example of a rotator cuff repair right here, or tear right there. So the patient in my case, he's a 28-year-old male. His past medical history includes that he had a left rotator cuff repair 2 years ago. He works as a painter, so in this case, with painting, he's going to be putting a lot of stress on my shoulders, and it's a pretty intense job as far as that's concerned. And he has had surgery after 3 months of progressively increased symptoms in his right shoulder. So an initial evaluation, he is 6 days status post right rotator cuff repair. So the patient presents with muscle guarding. So the muscle guarding is probably a result of pain. When he moves in a certain way, the pain's making him do some weird movements. With that pain, he has disturbed sleep. It increases with sitting without a sling, and side lying, and any active movements. He has shoulder flexion, abduction, and external rotation deficits, and he sits in a slump and has increased kyphotic posture. So findings to reassess each session. So each time we want to look at his pain level and what may be causing it. So is there any positions or things he may be doing that's causing him more pain or increased pain? Objectively, we want to look at range of motion. So the first, up until the reevaluation at 8 weeks, we're mainly focused on passive range of motion. So we want to increase the amount of passive range of motion he has. And his posture, we want to fix his posture. So we want to decrease the amount of kyphotic posture he has. So the patient activity, education activity. So since he has kyphotic posture, we're going to be working on a shoulder squeeze, scapular squeeze. And this retracts the scapula and strengthens the scapular stabilizers and the retractors back there, so he's not sitting in so much of a slump and his shoulders aren't rounded forward. And the prognosis for this patient, given his progress at reevaluation at 8 weeks, he will probably return to full function. His passive range of motion for right shoulder flexion, abduction, and external rotation at this point almost matches what it is for his left shoulder. He's now working on active range of motion at this point. He doesn't have to wear a sling, and he doesn't have any more pain at night during sleep. And he can lift up to 5 pounds, so the doctor put him on a 5-pound lifting restriction. Also, if he can fix his kyphotic posture, he won't have to wear a brace when he returns to work or when he does any of his daily activities. And then 2 to 3 more months, he will probably have full function. And the next phase of the rehab is in 4 weeks, so at the 12-week post-op mark. And at this point, we're going to further work on strengthening and PREs and things like that. After this video, I have a demonstration of the joint mobilizations and home exercise. And then in that video, I do a posterior glide, grades 1 and 2. So in this case, we're working on getting pain and maybe getting a little bit more shoulder flexion, range of motion. Also, I'm going to be doing and demonstrating table slides. This helps increase passive range of motion for his right shoulder in the pain-free range. So I have a demonstration of these after this video, and after you see those, thank you for watching. I have my patient here, Taylor. The patient in my case has flexion deficits, passive range of motion flexion deficits. So what we're going to be doing is posterior glide of the shoulder joint here. So just going to distract it a little bit. Just do a slight push down and out. And usually you want to do grade 1 and 2 closer to the surgery, and then you can do grade 3 and 4 further out, 4 weeks or so out from the surgery. Grade 1 and 2 is going to help get some pain, and 3 and 4 is going to help stretch the tendons some more and get some more range of motion, but you don't want to do 3 and 4 too soon. So the next thing I'm going to be doing is demonstrating a table slide exercise. And what this is going to be doing is helping the patient passively increase the amount of flexion they get in their shoulder. So Taylor, what I want you to do is you can use a rag on the table to kind of help decrease the friction. So you're going to have it, put your hand on the rag, and you're going to keep it straight back, and you're going to lean forward as far as you can in the pain-free range. So once you start to feel pain, come back and go forward again. Come back. We're going to do 2 sets of 10, and I want you to do that twice a day, okay? Can you do that for me? Good. Just go until you feel pain, and if you do, stop and come back. Okay.
Okay.
You have any questions about that?
No, I don't.
Okay.